Good evening, respected seniors. I think we'll go ahead with the advances in cataract surgery session now. First speaker is Dr. Maipal Satyas. I think you can play his video.
Asked to talk about femtosecond techniques in hard and mature cataracts. Now, these are two topics in which there could be some overlap, but basically, I'll be considering 2 points. One is the hard cataract as to how to avoid the complications, and that would be dealing with the hardness of the nuclei. And second would be in the cases of intumescent cataracts, the major problem is to get a good capsular access. Now let us look at the first challenge, which is because of the hardness of the nucleus and why it is a challenge. Now there are several studies which have come, including the important Swedish capsule rupture study, where it has been shown that if you are working with hard cataracts, white and brunescent hard cataracts, they are often associated with an increased risk of posterior capsular rupture and complications which are there. Now, how do we avoid these with the use of the femtocataract is something that I'll be talking about. In any patient who is hard intumescent, there needs to be a good pre-operative evaluation that has to be there, which should consist of first to evaluate in the OPT whether the pupil is dilating or not. Often nowadays, old patients, especially males, have the use of tamsulosin, which causes a increase in the problem. The second is that the assessment of the corneal endothelium needs to be done because hard cataracts have been sitting in the eye for a long time, and these are usually seen in old age patients. Zonular integrity is the third important thing. The morphology of the cataract and the inability to have a good posterior segment evaluation is the fifth thing. So these are the five important considerations that need to be looked at preoperatively. Now, why does hard cataract pose a challenge? The first thing is that because it is hard and because it may be associated with intumescence or there may be liquefaction, there is a compromised visibility, and this leads to an absence of the red reflex. So various steps would be difficult, and there is also the milky fluid which is there. Also, in addition, because the cataract has been sitting for a long time, there is a difficulty in the capsular access which is there. And in addition, there could be capsular changes which could be in the form of fibrosis, etc. And the poor visibility would compound the problem of getting a good capsular access. Further, in case the cataracts are swollen, there is a reduction in the AC depth, and that would also cause a little problem and will give you less space for surgical manipulation. In addition, the problem of corticocapsular adhesions would make hydrodissection, rotation, etc. more difficult. But the major bugbear is on the nucleus, which is a leathery fibers which will be difficult to separate completely, and it is very difficult to break the backbone of the nucleus, and therefore you end up in problems of having difficult separation and increased risk of posterior capsular rupture. Now, when you are looking at the femtosecond laser, it gives you a hand to improve your outcomes and to reduce the complication rate. As you all know that femtosecond laser is attempting to make the cataract surgery into a refractive procedure, and the important things is that a hard cataract patient should not be deprived of safe predictable outcomes and premium IOL options, and this is what the femtocataract is going to afford. Now, there are the several studies when you are looking at the nuclear disassembly. There are several studies which have clearly and categorically shown that in the femtosecond laser group, if you are looking at endothelial cell loss, this is 7.85% versus 19.96. So, harder the cataract, more is the effectiveness of the femtocataract in reducing the amount of endothelial cell loss. Similarly, if you look at the ultrasonic power that has been used, it goes down to about 14.38 as a percentage from 21.94, as also the EPT etc. that is used, or the actual phaco time that is used, is also significantly reduced. Harder the cataract, therefore better is it to use the femto laser. Now I'll show you two videos. Now this is one patient who came to us with a black cataract, and as you can see that there is the patient who has undergone the femto procedure. Now in this particular patient, we were thinking whether we should do the femto procedure or do this patient as an SICS. Now the important thing that I wish to show is that we went on and did the femto, and you can see that these are the cuts which are available, which can be seen. you have to increase the capsulotomy size to about 5.2, 5.5. Now just watch here. You can see that the disassembly, you can see these air bubbles coming, and you can see that the disassembly is much easier than it would have been if these pre-cuts had not been happened. You can see the ease with which you can disassemble. And mind you, just watch, again watch the disassembly, and you can see that the nucleus that is coming out is actually rock hard. You can see the color, and it's black. It's not even a brown cataract, but it's a black cataract, as you can see. And we have been able to disassemble this nucleus. Now let me just take it forward. You can see that the ease of disassembly, again you can see that the ease of disassembly is there, and the pre-chops have been done, which are very clearly visible. You can see again that this is the last piece, and we were able to finish this particular procedure even in this black cataract because we were able to have a good nucleotomy that is there. Now let me show you another case where we have again done the femto procedure. You can see that this has been split into, we haven't done any softening, but we have just made them into good pieces. And you can see that there is a good capsular excess. As I told you, that the capsular excess needs to be a little larger, so that even if the nuclear pieces are slightly large, you need to take it out. Here we always prefer to use trypan glue if you feel that the capsular excess may have a tag at a particular point, and we can see that with this capsular excess, we have been able to get a good capsular excess. Now again, I will show you here. Just watch. See here, this is the pre-cut area which is there, and look again at the bubbles that are coming out. That means that the plasma has been created right up to the posterior plate, and again you can see a dark brown black cataract which is being sectioned pretty well and easily. So you can see again in this particular case that you are able to section the nucleus pretty well. So this is as regards the nuclear disassembly in a hard cataract, that a femto is able to cut through brown and black cataracts as long as the visibility is maintained, and we are able to get these good pieces which is there. Now let us come to the second part, which is the intumescent cataracts. Now when you are looking at a white intumescent cataract, the steps that femto does is that it enhances the safety and predictability of achieving a perfect rhexis. That is something which is very important, and I will show you. But you have to, as a caution, always watch for tags and remember to stain, because if there are tags, you will want to remember to stain. That is something very important. The white cataract may have limited nucleotomy because the focusing does not happen, and if the nucleotomy is limited, if any at all, then you have to just be sure that the most important thing that you are doing in an intumescent cataract is to get a good capsular excess. In addition, you can see that if there is an astigmatism, then you can actually take care of the minimal astigmatism up to 1 to 1.25 diopters with the femto laser. Now let us just see a white barrier, as I call it. Now this, you can see that the nucleotomy is not good, but here you can see there was a boom. There was the intumescent cataract which was there. There was a lot of fluid that came out. And what is important in this particular case is that because it is a closed chamber, just watch here. This is an intumescent cataract, and we have stained, and you can see that there is a total capsulotomy that we have been able to get. So the most important thing, if you are doing an open chamber technique, whether you are doing a nucleotomy with a needle or a Neutratas forceps, the chances of having an Argentinian flag sign and runoff is there. So the important thing in this intumescent cataract is, again, you can see there is a good dissection that has happened, and we have been able to get a good nucleotomy. Let us go to the next case. This is a case of a phacomorphic glaucoma, and again here you will see that if I had gone in and done a nucleotomy, a capsulotomy with a needle, there would have been a runoff. But just watch in this particular case. This is a phacomorphic glaucoma, a doctor who came to us, and we are wanting to, these are the incisions. I'll just go forward. You can see here that we are making the settings. You can see the angle is so very obliterated and narrow that it is clear that it is a phacomorphic glaucoma, and you can see that the nucleus which will come into view is very swollen. This is the arcuate that we are adjusting, and we are accepting it. And let us go on to look at the amount of the nucleus, the shallowness of the interior chamber, and now see the capsulotomy that is happening. Closed chamber, release of milky fluid, but we have been able to get away without Argentinian flag sign because of the importance of the closed chamber capsulotomy that is happening in a femto case as compared to an open chamber capsulotomy that you do otherwise. And again, you have to use the trypan blue and see that this is again great, and you can the capsulotomy is complete, and you can see that we have been able to get out the nucleus, and this is a crystal lens that has been implanted in this particular case with good outcomes. So finally, I will just want to show you again, when you're looking at an intumescent cataract with a hard nucleus, and you are also looking at fibrotic changes. In fibrotic changes, you can see that a capsulotomy done by a femto, this is a post-traumatic case, the capsulotomy done by a femto will still give you perforations in the capsule, which would be like a postage stamp. So just look here, you can see that there is the capsulotomy which is complete in this particular area. You can see it is complete, and you can see that this is fibrosis which is there. And once there is the fibrosis which is there, we will be able to just look at the perforations that are there, and this connects. So it is may not be complete. You are increasing the energy delivery onto the capsule in cases of fibrotic capsules, and you are getting micro perforations which are easy to connect with each other. So you can see that these are easy to connect. Again, you can see that we are easily able to connect, and you get a complete capsulorhexis. Mind you, if we were trying this with our needle or with a Nutratas forceps, we would never have been able to get this. So the important things to end, what I will wish to say is that the important things that I have told you is that femtocataract helps you in nuclear emulsification and disassembly. The incomplete separation of nuclear fragments that can happen normally after chopping does not happen because you have gone through and through in these hard leathery cataracts which are tenacious with the femto, and there has been a disassembly that has already happened. So important thing for you to realize is that this disassembly is good because there is an absence of an epinuclear cushion for protection of posterior capsule, and towards the end you have to use moderate phaco-parameters, and good viscoelastic with chondroitin sulfate should be used. In case you still end up with the posterior capsular tear, what is important is that the early detection should be there, and this will lead to optimal management. And management depends upon the stage of surgical procedure that you are there. A dispersive OVD tamponades a posterior capsular tear and enables completion of phacoemulsification in a post-flax patient. Anterior vitrectomy may be required if you still have a vitreous collapse. So to sum up, I will say that the post-operatively, the consideration because of the prolonged surgical time, you need to use intensive topical steroids and NSAIDs and atropine cycloplegics, which are very, very important. IOP needs to be monitored very, very closely, and this would reduce the AC inflammation and CME that could possibly result. So femtocataract assisted surgery is really beneficial in cases of hard cataract, in cases of intumescent cataracts, in cases where there could be some fibrotic changes in the capsule. So these are my preferred cases where I would definitely push the patient towards getting a femtolaser cataract surgery done because of the advantages that I have enumerated. Thank you very much for your kind attention, and it was a pleasure being here.
Thank you all. I think Mahipal, it was a recorded video that was presented. We can maybe have a brief discussion before we go on to the next topic. Arup, I think you don't use the femto much. What are your thoughts on this?
Thank you, Dr. Ramamurthy, for asking me, and it was a very nice presentation from Dr. Mahipal. The points that is highlighted are very true. An intumescent cataract, the really swollen ones, the anterior capsulorhexis becomes a problem, even for a surgeon who has been in the field for a long period of time. So definitely, if femto assists in making the rhexis simpler and safer in 100% of the cases, it is definitely a point that has to be taken in favor of the femto laser-assisted cataract surgery. Likewise, even for hard cataracts, so we have been doing the hard cataracts over a couple of decades with all kinds of machines, but we get stuck even today at posterior nuclear plate situation. Whenever there's a difficulty, we have noticed that it is the posterior nuclear plate. So maybe if the posterior nuclear plate is already taken care of by the nuclear softening or whatever, strategies that have been used. So that could definitely be an advance. But what I'd like to tell you that even if you don't have access to femtolaser assisted cataract surgery, you can still perform a fantastic cataract surgery in these challenging situations in most of your cases. So it is nothing to get disheartened that you don't have it and your patients are getting affected. No, patients are still coming out with wonderful results by surgical skills and in most of the situations.
Your thoughts, Dr. Samar?
No, it is, we are using it, but gradually taking the high risk cases. But as Arup said, that Rexis is the main thing during intumescent cataract, and there it has been taken care.
Actually, over the time, as we've been using it, initially we used to take a lot of time using the femtolaser, and then at times we felt that why do a femtolaser and waste so much time. But now, as the fluidity has come in over the years now, and we try and tend to do more of the cataracts, the hard cataracts, the soft cataracts, and even the normal cataracts. If patient is willing, we give them a choice for this. And it's really much easier, much safer, much faster now that it has become so. We know of centers where the femtocataract is done, the femtolaser part of it is done by an associate surgeon, and the rest of the part, the management of the nucleus, removal of the nucleus, as well as the lens implantation done by another surgeon. So this also improves the fastness, the speed in which the cataracts can be done. Because at one time, this was an issue that once you put the patient onto the femtocataract platform, it is going to take nearly twice as much of time getting the patient, shifting the patient and things like that. But these are aspects that can be thought about and can be considered with every unit, whatever it is.
The interesting part is, you see all this meta-analysis that comes in waves, over every year, we have 2 or 3 large studies, which it definitely shows that, there is no definite long-term advantage of femtolaser assisted cataract surgery over the routine phaco. So this is the, universal conclusion that is taken, that is, concluded, that is presented in these publications. But I definitely feel that those who have femtolaser assisted cataract surgery facilities, they always feel more comfortable with it. So I think that is fine. But we must keep in our mind that, again, what Partha mentioned, that results have become better and all that. It has become better compared to the previous platform of Flex, not with respect to routine manual phacoemulsification. I mean, this is what the evidence has got to say.
There seems to be a consensus between all of us. Well, it's possible to do excellent cataract surgery even in these difficult situations. I think today these hard cataracts, intumescent cataracts, where we feel that the femtosecondary laser really has a role to play. Whether it's an intumescent cataract, even a hard cataract, getting a perfectly centered, well-rounded rexis is extremely important. That in a repeatable fashion, even if it's a fibrotic capsule, you get a template which you can extend, and that assists your surgery. And of course, in hard cataracts, if it is even it's brown or black, there is a certain amount of laser passage and segmentation and nucleus fragmentation that happens. That definitely assists. So I do believe that while it's possible to do without these addition of the flags, but if you have it, using it, especially in these cases, a definite advantage. And especially in intumescent cataracts, I strongly advocate to my patients that they go for a femto, and I don't mind even doing it at a concessional price.
As regards the post-op management, I think Dr. Mahipal mentioned in his last slide, use of atropine eye drops and use of, so do you think, all of you agree with that? Or because we have not used atropine even in routine cataract surgeries?
No, I don't think atropine is available in my clinic at all. Only for cycloplegic refraction in small children. Otherwise, yeah. I don't think. Maybe,
the post-operative steroid regimen is the same as, for a soft cataract or a hard cataract. For the manual phaco also, I don't think there is any difference that takes place.
Can we go on to the next topic?
In fact, I think we have gradually switched over to softer aspects on the steroids. The steroids have gradually, we used to use prednisolone acetate at one point of time. We don't use it at all anymore. So just about 1 week of steroid antibiotic combination, stop the steroid antibiotic, and then loteprednol for the next two 2 weeks, and the NSAID goes on for about 4 to 6 weeks. That's our standard regime now, both for the Femto platform as well as for the FECO platform.
Thanks, Partha. I mean, can we go on to the next topic?
Yes, sir. Next, we have a very good teacher and speaker, Dr. Ramamurthy sir from Coimbatore Eye Foundation Chairman and ex-Chairman Scientific Committee and ex-President of AOS. Sir, he will be talking to us about mixing and matching IOLs to maximize visual outcomes. Sir, please.
Thank you so much, Elan, and your team for putting such a vibrant program together, 3 days, excellent scientific material. It's indeed an honor to be a part of this session. The topic has already been said. By way of financial disclosure, I am a consultant to both J&J and Alcon, and some of the products I will be alluding to are manufactured by these two companies. Basically, today, as cataract surgeons of the third millennium, our goal is to provide a range of continuous vision from distance, intermediate to near, without compromising on the quality of vision and reducing the dysphotopsia to the maximum extent possible. So essentially, what I'm going to take you through is a series of screenshots of our own patients, where we have played around with the capabilities of the different premium intraocular lenses that are available to us, and perhaps leave behind certain take-home messages, which you can go ahead and employ in clinic tomorrow. I think almost all of us are into multifocal toric lenses, though the numbers and the percentage done might differ, but I think all of us are slowly shifting over to them and adapting them. One of the most commonest way of implanting these lenses to implant similar lenses in both eyes. I've been doing it right from my array days, then to rezoom, then to the multifocals, etc. This is the case of LRCS with Symphony. This is a usual plan, right and left eye. And almost in 80% of the cases, it works out well. You can say there's a garden variety of cataract. Biometry shows just a 24 diopter intraocular lens to be implanted in both eyes. And that's what we go ahead and implant, and the patient is quite happy. You see that in spite of the fact that we have been told that the EDOF lenses are somewhat deficient for near vision, you find that in this patient, the first eye worked out to 6.6 and 6 and 20/20 intermediate. So went ahead and implanted the same lens in the second eye. So bilaterally implanted, the patient did well. And this is often the scenario irrespective of the type of multifocal intraocular lens that you are implanting. What if you do not, or most often leave 2 weeks gap between the first eye and the second eye, is not just to reduce the chance of infection, but also the fact that we learn a lot from the first eye intraocular lens implantation to play around with the power that we implant in the second eye. This is a patient who got a EDOF lens in the first eye, very similar to the, hello? Can you see me and hear me?
Yes, yes, sir. Sorry for that. Yes, sir.
Okay. Very similar to the scenario there. Here again at 22.5. But what you see over here is after the first eye implantation, the patient was quite unhappy with the uncorrected near visual acuity because he needed a +1 diopter for his reading, even though as far as distant vision is concerned, it was excellent. So what did we do? We went ahead and implanted the same EDOF lens, but we aimed at a -0.75 diopter myopia in this eye. Basically, what the optical biometry showed us was a 22.2, but we implanted a +23 lens in this eye. So bilaterally implanted, though it did not affect the distance vision significantly, this eye ended up with the N6 vision, because of which bilaterally implanted, the patient was quite comfortable for all distances of vision. Let us look at another scenario. Here is an 80-year-old male patient. He was essentially extremely keen on picking up the newspaper and reading in the morning without the need for glasses. He was not driving outside. He was not interested in his computers or iPads, etc. I think we still come across quite a few patients like this in our practice scenario. And what you see over here, something similar to what you saw in the earlier two cases. But here again, as far as the near vision after the first eye was implanted was concerned, the patient was not quite happy as far as near vision was concerned. One of the lenses I have used very widely in the earlier days was the +4 diopter multifocal intraocular lenses, and still we have a stock of them. I feel even though there's a large trough where intermediate vision is absent and dysphotopsia may be a concern, is one of the lenses which gives excellent near vision. And since the patient's persistent complaint was poor quality near vision, what we went ahead and did in the fellow eye was to implant a Technis +4 diopter intraocular lens. So what you find in this patient is that with a Symphony in one eye and a Technis +4 diopter in the other eye, the patient ended up getting good vision for all distances. So it's essentially titrating the lens you implant in the second eye, depending upon the patient's requirement. Look at a similar scenario, only the difference here is a 55-year-old male patient. And these slides are about 2 or 3 years old when I was using more of Symphony lenses in those days. And what you find here is again a straightforward patient, but this 55-year-old was an active businessman, wanted to drive on his own, used to go playing golf, and was also using devices like the laptop, computer, iPad, etc. And what we did in this case, even though, as you saw in the earlier slide, even though he got N6 vision with his Symphony eye, he was saying that the kind of vision that he enjoyed with his glasses was what he did not have with his Symphony implanted eye. So what we went ahead and did was to implant a 3.25 diopter at Technis. Basically, in this patient, intermediate vision was also important. As you can see over here, in the eye in which the Symphony was implanted, the intermediate vision was better, 20/40. While in the eye where the +3.25 is implanted, it was 20/25 in the Symphony eye and 20/40 in the eye which received the Technis +3.25. But bilaterally implanted, even though the patient had a small myopic astigmatism, the patient was quite comfortable for all distances. So it's not just the type of refractive outcome, you also have to tailor make the outcome according to the requirements of the patient. Symphony intraocular lens implanted in the first eye of the patient. You can see just a 0.93 diopters of astigmatism against the rule, so somewhere between against the rule and oblique astigmatism. So for cost reasons, we went ahead, we thought that it's just a small astigmatism, went ahead and implanted this. But what the patient ended up with after the first eye implantation was he had a 6/9 uncorrected visual acuity, required a -0.75 diopter of astigmatism correction. So we said that we will take care of it 3 months later by doing a laser vision correction in case he wanted. But while waiting, we said we'll go ahead and implant a Symphony toric intraocular lens. And as you can see, what he needed was XT 2.25, a significant toric intraocular lens that was needed, in spite of the fact that the astigmatism in both eyes was almost similar. And of course, as was expected, what you find in the eye which ended up receiving a Symphony toric, he ended up with a 6/6 and 6 vision and an excellent intermediate vision also. So even though we did offer to correct the residual astigmatism, because bilaterally implanted, he was quite comfortable, decided to stay that way without any further intervention. Another example, fast forward about a year, where the Panoptics has just become available. The Panoptics toric had still not come into play. This is a 0.87 diopter at 18 degrees. Again, what you would say a small degree of astigmatism. But then unhappy patient at the end of a very comfortable surgery, where you see that the uncorrected vision is 6/18. Often the kind of refraction that the patient has and the kind of uncorrected visual acuity do not always correlate. Quite unhappy with the kind of visual acuity that he had. And exactly the similar situation as what we did with the Symphony toric, where in the second eye, while we are waiting, you see this patient needs a Panoptics toric of T3 variety. And 2 weeks later, we went ahead and implanted this. And as expected, you find that the eye which received a toric Panoptics ended up with an uncorrected visual acuity of 6/6. This patient actually went ahead and underwent a laser vision correction for the residual error in the first eye, and bilaterally implanted, the patient did well. This is just to emphasize the fact that irrespective of the type of multifocal intraocular lens that you implant, it's extremely important either with this laser arcuates, limber relaxing incision, or by using toric intraocular lenses, which work the most accurately. It's important to address the anterior corneal astigmatism in each and every case. I am often asked, what is your cutoff as far as cylinder toric lenses are concerned? It's important to say is not just the amount of astigmatism, it's also important whether it's with the rule or against the rule. Nowadays, we actually, our go-to formula is the Barrett toric calculator, and we see whether it indicates the toric lens is indicated or not and decide based upon that. You can see this is against the rule astigmatism, the sub 1 diopter, but what the patient required was a T4 toric intraocular lens. But here, contrast it with the rule astigmatism, again about a plus 0.75, but what it tells you is a non-toric intraocular lens that is needed. Is because the against the rule astigmatism, which is most often prevalent in the posterior corneal surface, is taken into account. So it's not just the degree of astigmatism it's important, but it's also axis of astigmatism, and it's best to feed into the toric calculators and determine whether that patient will do well with a monofocal toric or a multifocal toric or just a plain non-toric intraocular lens, and our entire counseling is directed towards that. What about patients who have already undergone a post-LASIK laser vision correction, are now present to you for cataract surgery? If you have access to the preoperative data, it's excellent. But today, the formula available where the preoperative data is not very important. But the most important criteria when I offer multifocal intraocular lenses for patients who have undergone laser vision correction is whether the amount of refractive error the patient had initially was very high or low. If it is low and subsequent to the laser vision correction, the patient had excellent uncorrected visual acuity and now has presented with a cataract, that is an indication to offer a multifocal intraocular lens. And in these cases, I tend to offer more the EDOF lenses rather than the trifocals or the bifocal lenses. And again, having a regular corneal anterior surface, a well-centered ablation like this in the right eye as well as the left eye is extremely important. The eye test tells you there is very little of corneal aberrations in both the eyes, and it's essentially in the lens. So what you see over here is we use the Barrett 2K formula in this case, and this is the kind of intraocular lens, the Symphony, that was implanted in both eyes, and it's possible to get excellent distance and as well as uncorrected near visual acuity, even in these carefully selected cases of post-LASIK situation. This was a patient who underwent a significant myopic astigmatism. As was our usual practice, we advised the aspheric single piece. The surgery went off well, our formula worked well, and the patient ended up with an uncorrected vision of 6 by 7.5, but needed a plus 2.5 diopter. And this is a patient who was 50-year-old and was saying, can I get back my glass-free vision I enjoyed for so many years? We did tell them that this is not the usual way we do things, but in case there is a multifocal option available, and since it had worked very well for the patient, the biometric calculation, we went ahead and implanted a Symphony lens in the second eye, and after significant discussion. So what we ended up in this situation, as you can see, even though the first eye required a plus 2.5 diopters, because we hit the bullseye in the second eye, bilaterally implanted, and since the visual requirements for near vision was also limited in this society lady, her specific requirements were well met, and this is a kind of combination that we dealt with for this particular patient. This is a patient who underwent a Symphony toric some years back, had a significant astigmatism of 2.58 and against the rule astigmatism. And as you can see over here, the patient achieved excellent distance visual acuity, but required a plus 1 diopter for near visual acuity. The patient had undergone a LRCS with a Symphony toric, so obviously he was not quite happy. And that is a time when the trifocal toric had become available. And as you can see over here, the amount of astigmatism is almost similar, but what was needed in this eye was a T6 panoptic. So implanting in the earlier eye also had received a Symphony toric. So as far as the toric correction is concerned, both these lenses worked equally well, but the panoptics had the advantage that it could take care of the near vision quite adequately, so that with this kind of a mix and match, we could address the specific patient's needs. This is a situation where there was a patient who had undergone a toric intraocular lens by a colleague of mine, a lawyer actually, had excellent distance visual acuity, just needed a plus 2.5 for reading, but had persistent complaints of negative dysphotopsia. because, and this patient basically was put on lubricants, counseled the primary surgeon himself dealt with him almost for 4 months, then subsequently referred to me. He stayed with me for another 2 months. He said, you have to do something. I did not want to bring the lens out of the bag because the primary correction was excellent. So what I did was to go ahead and implant a Salcoflex lens, which is overall diameter of 14 millimeters and has a 6.5 millimeter optic, has a rounded optic edge which completely covers the square edge of the primary lens that was implanted. And it's a fairly simple surgery to do. And once you do this, you find that even on the first post-operative day itself, this patient completely was bereft of his severe negative dysphotopsia. Actually, it was an extremely happy patient, and I have done this in about 3 patients so far. This is just the post-operative pictures showing you the 2 lenses. You can also see it on the OCT. This is just the last of my lens presentation. This is a patient who had undergone a lens in the second eye, implanted a multifocal lens, wanted some kind of correction for his near vision in the first eye too, which had been operated in the years back and already undergone a YAC capsulotomy. So now we have a reasonably priced trifocal lenses, piggyback lenses like this available in the Indian market itself. And this is exactly what I'm implanting. Mind you, this patient had a multifocal, a trifocal lens in the other eye, recently operated. And this is a piggyback trifocal that has been implanted in the second eye. So suffice it to say, I think today with the choice of lenses that we have, our understanding of them, we most often counsel our patients that in spite of all the technology that we have, it is less dependence on glasses, not throwing away glasses, possibly of dysphotopsia. And I believe the second eye surgery is the greatest opportunity for us to hit refractive accuracy, more than refractive accuracy, patient satisfaction. Thank you so much for your kind attention.
Very nice presentation, Dr. Ramamurthy. You have shown the whole gamut of situations that one could encounter. See, I would request that you keep your opening slide for a longer period of time for us to count the number of branches that you have. And every second meeting that I attend in a webinar meeting, I find that your number has gone up by 1. So keep congratulations on that. See, another thing, I just wanted to tell you that, I think one of your first few cases you had mentioned that using the first eye's prediction error to titrate the power for the second eye. So I think, there is, instead of going about it in an arbitrary manner, it is better to follow a dictum. See, a couple of years back, there's an article by Barrett and co-authors where if both eyes have the similar morphometry, and there's no transcription error and there's no wrong IL-power implanted, then for the second eye, you need to correct only about 30% of the prediction error that was seen on the first eye, if you're using Barrett Universal 2. And if you're using the other formulas, then it comes out 50%. So you have to set the target refraction when you select the IL-power for the next eye, for the second eye, in an appropriate manner. I try to follow that whenever I do monovision for my patients. So that has worked pretty well. And so now the other one patient that you had mentioned, that Symphony and Panoptix, they have different optics, optical principles, different biomaterials. And I mean, what is your experience on mixing multifocal lenses or trifocal lenses of different biomaterials and different optical principles? And I would like to get the opinion from the other panelists too on this.
To answer your first question, very pertinent comment, Arup, we do get refractive inaccuracies, but the entire series of cases that I showed in this presentation was not any biometric error. Basically, we were able to hit the bullseye, but the patient was not satisfied with the visual outcome in the first eye because of inadequate near vision or Lebbigen astigmatism. So we went ahead and implanted in the second eye a lens which could address that, and bilaterally implanted, they did well. And usually you said 30%, what I use is 50% of the refractive error that is there, and it works reasonably well in my hands in case there's a refractive inaccuracy. And as regards using 2 different lenses, I think there's not enough literature out there to tell which lens you can combine with which one. But I have found in my practice that as far as you, even if there is a symphony in one eye, it's a hydrophobic acrylic lens. The panoptics is also a hydrophobic acrylic lens. Bilaterally implanted, basically the EDOF lenses are inadequate for near vision. And the trifocal or the Synergy today takes care of that quite adequately. What I find is that the patient doesn't know, the eye doesn't know, as far as the two eyes are seeing well. Most often these patients are quite comfortable. We are doing this quite routinely because there was a point of time when we were doing a lot of Symphony, and that was our go-to lenses. Some of these, though this is an excellent lens, as we all know, for near vision, it's somewhat deficient. And now with the availability of trifocals, when they come for a second eye with this problem, we have done quite a few, either with a trifocal or a Synergy or the toric version, and they have done well.
Any other inputs from Partho or Dr. Harbansh,
Yeah.
sir?
Sir, actually about this part of the mix and match, this is something, we learned quite early when we were doing the multifocals. So with the multifocals, at the time of counseling, I used to specifically tell the patient that we would be doing this multifocal, and if required, we might for the other eye do a little tailor-make change of the lens if required. Patients were very, very specific that I'm going to put the same lens in the other eye. And it definitely needed some amount of counseling to say that for whatever would be required, we would take a call once the power is stable and then do the other eye. So this, even today, we follow similarly. However, the time gap of the second eye has definitely come down. And we do still implant the requirement as per the need of the patient, as well as if the patient is comfortable, totally comfortable with the first eye, and we are happy with the correction of the first eye, then the second eye gets the same intraocular lens. And this actually happened when we were doing the Symphony, and quite a few patients kept complaining, no, doctor, but I'm not seeing near, despite having been counseled that the near vision would not be well corrected, and it's only for the mid as well as the distance. So then we planted quite a few trifocals along with the Symphony in the one eye, first eye, and telling the patient that this is the thing, and this is a lens of a different nature, and this is going to assist you so that both eyes you can see well with both eyes, but you're not supposed to come right and the left, and that will not work. So counseling in the first instance is very, very important, and then modifying the stand to for the second eye. However, right now we use mostly trifocals, and the EDOF lenses I do not use very regularly. And with trifocals and with the Synergy coming in, patients are quite happy.
True.
I have a question to Dr. Ramamurthy and Partha. Is Synergy causes more halos and glares as compared to Symphony, or more or less same?
I think, all these multifocal intraocular lenses do cause glare and halos. Well, I've had, even the company's literature, their claims also say that all of these lenses work on the principle of splitting of light. So it is there. But whatever Synergy patients we have, anecdotally, we have not done a study. These patients do not, majority of them are quite comfortable, and they're not complaining more than what the others are. But this has been our experience with Symphony, and even with the currently available trifocals, even with some of the Indian multifocal lenses. So I believe that there is once in a while you come across a patient who is complaining quite bitterly of dysphotopsia, but majority of these lenses seem to have some way of addressing that, so that the problem of dysphotopsia has significantly come down. But you can never say that. I don't think there is a single.
Actually, I wanted to know, because I have put a lot of Symphony lenses without any problem. So some of them definitely have some near vision issues. So when they come for the second eye, whether putting Synergy will give more dysphotopsia and patient will complain of that, it's better to do the mini monofocal of a Symphony or go for Synergy. That was my question. If patient is getting more discomfort with Synergy as compared to Symphony, then probably making it -0.5 of the Symphony will be better, or giving the Synergy will be better. That is what is my question. Whether Synergy causes more dysphotopsia vis-a-vis Symphony.
I would actually go for Synergy without much hesitation, simply because, both the Symphony and Synergy are based on similar optical principles. Actually, the HLA design of the Symphony does something from the intermediate to distant vision, That's exactly what in Synergy it does from near to intermediate vision. So the material, the all other components being exactly similar, I think, of course, if it's just a 0.5 diopters, maybe a micro monovision will also work. Otherwise, a Synergy will be the way to go. I think we can go on discussing this, but we have still many very good speakers to follow. So if we can go on to the next speaker.
Yeah, only one point I will like to highlight. Whenever you go for Synergy, you take first plus instead of taking the minus, because otherwise your reading distance becomes very close and halos becomes much more. As compared to Symphony, you go for the little minus. Synergy should go for a little plus. There is no harm.
Point well taken. Now I invite Dr. Arup Chakravarti to speak on presbyopia correcting IOLs in glaucoma. I think he's a very eminent, doesn't require much of an introduction, very eminent cataract and glaucoma surgeon practicing in Trivandrum, and obviously he has taught us all for decades now. Over to you, Arup.
Thank you, Dr. Ramamurthy. So, Ilan, I had already given a presentation, which was timed for about 14 to 15 minutes. Can that be played?
Yes, sir. Hall in charge, Vishal or Jyotsna, please play the sir's video.
Jyoti. Doctor, I didn't receive the. I didn't receive.
While they are trying to locate the video, should we go on to the next speaker?
I think it's a good idea. The next talk.
It's my pleasure to introduce my good friend, Dr. Partha Bishwas, our present chairman, scientific committee. Again, a very eminent surgeon, cataract as well as refractive, from the city of Calcutta. Over to you, Partha, for talking to us about lighting a candle for tender eyes.
Thank you very much, sir. And I thank Ilan and KSOS for giving this opportunity and sharing a very, very important aspect, which I very firmly believe. And this is the aspect of what we feel is supposed to be left to our pediatric, but I feel that it has to be done by all comprehensive ophthalmologists who are practicing cataract surgery. It is basic nature. 1.4 million eyes have preventable cataract in the pediatric age group. So 1.4 million blind children, and not possible to improve by just our pediatric ophthalmic colleagues. And this is why I is very elastic in
Partha, your sound is not good. Can you cut off your video? Maybe things will improve then. The connection doesn't seem to be very good. Your personal video, I mean. Samar Harbans, are you able to hear him? I am not able to hear him at all.
Not able to hear him.
Not able to hear him.
Jyoti, can you hear me?
Yes, doctor.
Dr. Arup Stock, I've just mailed it to you, ma. Just see, check that.
Okay.
Please play it,
Okay.
ma. Please play it.
Fine. While they're getting ready, I think we go on to Dr. Harbans Clark's talk. Hope both Partha will also join us. Harbans, Vice President AOIS, is going to speak to us about post-RK cataract surgeries.
Is my screen visible now?
Yes, very well.
So now we are getting a lot of patients who have been done RK a few years back. And just for the beginners to understand how the RK works, because my generation might be knowing that we used to give a paracentral radial incision. The paracentral used to get steepened, and there used to be central flattening, which keeps on happening throughout the life. So the challenges are, and what we have learned over a period of time is, what are the pre-operative, operative, and post-operative challenges, and what are the lessons we have learned after operating few cases. So pre-operative challenges, basically the keratometry, biometry, and how to counsel the patients are the key. So the issue is that maximum flattening is in the center while we measure the paracentral area, which is much steeper. Cornea is irregular and there is a wide variation in the readings. Optical biometry may not measure it because the lens star lowest reading is 34K. Then maybe ectasia with a very high keratometric values. We need to calculate biometry with the flattest reading. And the another important issue is that the relationship with the corneal power and IOL power is almost 1:1. That means one keratometric value wrong and you will get one diopter of a surprise. And if the keratometric value is more than 38, you have got to be very, very careful. So then we go to the IOLCal KSS.org and it gives us the optical biometer, pentacam, Barrett, minimum, average, maximum, and we need to take the maximum. So toric IOL to use or not will depend upon the quality of the data, agreement between the pentacam, optical biometry, and more importantly, refractive error, because in the irregular cornea, refractive error becomes the very, very important. Up to 15 degree of disagreement is acceptable. Amount is not so important as the axis is. Operative is very simple. We need to do the hypovolumic use to need the dispersive viscoelastic. It's better to make a scleral incision. Make sure that the cuts are not open up. Post-operatively, we need to keep in mind two things. One is the hyperopia may be transient because of the corneal edema, and they may be permanent because of the biometric error, or maybe the combination of that. So transient hypermetropia should be treated with the saline drops or ointments. Do the subjective testing every 2 weeks and do also the corneal thickness measurement for the additional information. If improving, keep on waiting 8 to 12 weeks, and the myopic shift up to 4 to 5 diopter over the 2 to 3 months is very much possible. So don't be upset if you find next day patient is not having very good vision or has got a 3, 4, 5 diopter of hyperopia. So I'll just show you a few of the cases. This was the case 1 who had a refractive error of -4 and -3.5 diopter at 170 degree and vision was 612, had a cataract. Now if you see over here, the optical biometric keratometric average keratometric value was 37.49, but there's excellent correlation between the astigmatism of the refractive error and the optical biometer. While on the pentacam, the refractive cylindrical power was more or less same and axis was also matching, but the keratometric value was 39.5. So when we calculated on the IOLCal, you will see that average IOL power was 11.73, minimum was 10.13, maximum was 13.56, which was also by the optical biometer. And this is because the optical biometer was having the flattest reading, much flatter than the pentacam. So you need to take a flatter reading. And I always target in these patients, and you can see the cylindrical agreement was very good, 80 degrees, 25 degree, 82 degree. So we went ahead and now I target -1. When you put on a -1, what we need is maximum was 15. So went and implanted ZCT 525, which will give 3.75 of a correction and a 15 diopter of IOL. So always target -1. This is the another case. And in this case, if you see that the astigmatism was 6.25 diopter at 172 degree, and the corneal average estimated the total power was 36.61, and the power which we were getting was 21 diopter. Now, once we went on to the pentacam, the astigmatism was same, more or less 6 diopter, but axis was 149.3. And once we calculated with the 0 and targeted -1, the -1, what we're getting was 29 diopter. With the 0, if you go by the biometric value, it was only 21. So what IOL power and what axis of the toric, because 149 and 172, there's a lot of variation. So now we did the refractive error, autorefractometer, and you can see that the refractive error was 164 degree. So this in a irregular cornea becomes even more important. So we went and implanted ZCT 800, 29 diopter at 165 degree. And if you say we went by the biometric calculation, it was only 21 diopter. I still patient was 0.25 diopter hyperopic. So take the maximum power, whatever is take the flattest K, and whenever there is a doubt on the corneal astigmatism, take the refraction of the patient. A spectacle perception is more important than this. This is another patient who had a 32 cuts. And if you see that, the power, IOL power, which we were getting was 10.5. And this is where the 41.64 was the average K. And this is 46.80, which is not possible because even if you take the average case 43, it has to become flatter. That means this keratometric value was being calculated at a point where there was a lot of steepening. So once we did the IOL calculation on the IOL calc, maximum was coming 11.52. We planned for 12.5 and did CT 600. And to our surprise, the patient had after a few weeks +9 and 4.5 at 140° 6.9. So that was the type of refractive error we got post-operatively because that keratometric value was wrong. So what is next? Piggyback IOL exchange of the power. So 1 month post-surgery, we decided to go for IOL exchange in this patient and we put on a 27 diopter lens. No toric IOL was used. Still patient had +0.5 spherical equivalent. And over scleral contact lens -4.5 diopter spherical, he could be improved to 6/7.5. So he had astigmatism and which was, he needed a contact lens. So what power now to be used? What I feel is normally when you see the optical biometry, the relationship, what IOL you get and what correction you get is 1:0.67. That means when you increase the power by 1 diopter in IOL, you get 0.67 correction, nearly 2/3 of that. So IOL power used was 12.5. Residual spherical equivalent was 11.25 into 1.5, 17. That means for 0, we needed to have something around 29.5 or 29 diopter. We used 27, patient is still hyperopic. And if we again target residual refractive error of -1, then patient needed 31 diopter. So normally with this experience, what I learned is that whatever is the residual refractive error, make it 1.5 times, add to the previous IOL use, and then if you are targeting -1, add 1.5 more. So that means if there is a low residual refractive error or a high residual refractive error, so depending upon that, you can calculate what IOL to be used. So in this case, there is another case where IOL power collection was totally haywire, +2 to -6. And so this was, in this case, we just removed the lens, and afterwards, post-op refraction was 13, and the secondary IOL implantation of 26 diopter was done. So the lesson learned is that flattest keratometric value, whether it's a pentacam or its IOL master, should be used. Do calculate online. Target refraction should be around -0.5 to -2 diopter. Never, I mean, if the cornea is just 4 incision, 6 incision, 8 incision, not so distorted, you can go for -0.5. If the cornea is more distorted, you need to have target -2 diopter or so. Any keratometric value, if is above 40, you are 100% calculating the paracentral area, or there is ectasia in the central part. Any biometric value below 18, unless patient is still a lot of myopia, you have to be very, very careful. And most of these patients needs IOL power of 24 to 28 diopter. This, if you calculate, I have tried to visualize certain situations and try to calculate if it was -3 and -8, if it was corrected by RK and some amount of hyperopic shift was, so what will be the IOL power? So that means any patient who is getting less than 24, 25, 26 after RK, probably you have got to rethink and see whether the keratometric values what you are getting is right or not. And if you are not so sure what lens to be used, IOL exchange and a secondary IOL is always an option. So you can opt for secondary IOL instead of putting the IOL on the first place. Thank you very much, Ellen, and thank you very much, the Karnataka Ophthalmic Society, for giving me the opportunity.
Thank you, Harbans, for that excellent presentation on a very difficult topic. A lot of discussion that can happen, but I think we have 3 more speakers and running short of time. Ellen, you want to exactly finish at 6 or a few minutes is okay?
Sir, 5 minutes is okay, sir.
Okay, then we'll just go ahead with the presentations and maybe time permitting, we'll have the discussion. Partha, are you reconnected?
Yes, sir.
Would you like the presentation?
Yes, reconnected, sir.
Please go ahead. Please complete your presentation.
So, sir, can you just guide me up to what time? What did I was this?
Start here. Okay. No, that earlier this thing was
a little earlier. Okay.
Yeah, this is fine.
Okay, sir. So this is just to reinstate the fact that we need to, as comprehensive cataract surgeons, we definitely need to take up the challenges of pediatric cataract surgery. learn pediatric cataract surgery the right way, because there are 2-3 aspects that are very different. And the first is capsular rhexis, the anterior capsular rhexis, because the anterior capsule is a very elastic membrane. So making a good capsular rhexis at times can be a little bit of a challenge for the initiated. Now, once you are initiated in this, then it becomes much easier, and the cortical matter as well as the nucleus is a very soft one most of the times and can be removed easily. The next important part is the posterior capsule, which will opacify if a posterior capsular rhexis is not done in pediatric cataracts. So first inflating the bag with a viscoelastic, and then making a small opening, and then with the posterior capsule, holding the posterior capsule with the rhexis forceps, and then carving out a small, approximately 3.5 to 4 millimeter posterior capsular rhexis is what is required. And then the viscoelastic has to be placed between the anterior capsule and the posterior capsule. And once the space is made, the leading haptic of the intraocular lens has to go right in the space between the posterior and the anterior capsule, and then the trailing haptic can be placed inside the bag. The anterior vitrectomy is mandatory to remove the scaffold of the anterior vitreous face. This is another patient in which we had a little bit of a challenge because it was a white cataract. The mother had rubella, and what we were apprehending is a difficulty in both the posterior capsular rhexis as well as removal of the cortical matter as well as the nucleus. However, we did place a 3-piece lens in the bag, and then we had to remove this plaque of the posterior capsule. So we cut it through with the MVR, and then with the vitrector, we made an opening approximately 4 millimeters in the center. And this was an opening that was fairly okay, and the patient definitely did improve on the vision. However, as you can see, there is nystagmus, and these eyes can have difficulties. This is a case with microcornea and microphthalmus, and we have the iris coloboma as well. So we place in the high molecular weight viscoelastic in the colobomatous area, and then the challenge is to do a good capsular rhexis of adequate size. As you can see that because of the microphthalmus, the anterior capsular rhexis is nearly extending to where the zonules are there attached. And removal of the cortical matter is not so difficult. The next part becomes difficult because of the zonules, which are not evenly placed. So the posterior capsular rhexis, as you can see, is a little bit of a challenge, but it has to be done well, and the lens has to be placed in the bag. So here we place the single piece lens in the bag, which actually, because of the flexibility of the haptics, it crowds in. And then at that point, after placing the lens in the bag, we place in the CTR to center the bag. After this is the anterior vitrectomy coming in, and this is a well-centered bag with the lens in place. Now, this patient had intumescent cataract, and after removing the milk of the fluid that came out from once we punctured it, the capsular rhexis had to be done exactly as we would do it, but with, of course, a microforceps. And the microforceps becomes a very important tool in these cases. And as you can see that my capsular rhexis is possibly not the best one, and we need to place the lens in the bag. So we can definitely err in the smaller side. So after doing the posterior capsular rhexis, we place the lens in the bag. And once the lens is placed in the bag, what we do find is the capsular rhexis is crowding over the lens. So we need to remove one little bit at that part so that it's a central capsular rhexis, because we must remember that this capsular rhexis is going to provide the tension forces for the next 40, 50, 60 years of this child's life. This is a case in which there was a posterior lenticonus, and we do know that with a posterior lenticonus, there would be deficiency in the posterior capsule. And we had a backup for such a position. And what we do is we do not do a hydrodissection, and we do a manual separation of the anterior cortex from the anterior capsule. And as we remove the lens matter and the what we do find is an opacified posterior capsule in the center. So we have to do a posterior capsulorhexis, and luckily we are able to fashion it. It is a little different again because the central part is opacified and it has to be circumnavigated. And once that is done, the opacified area of the central posterior capsule is removed by the vitrector, then placing in the lens inside the bag. And once the lens goes in, then the bag is well done. So let's look at the pearls for pediatric cataract management by comprehensive ophthalmologists. And this is important. Detailed preoperative examination is mandatory, and accurate biometry as much as possible is important. An adequate capsulorhexis, which has to be accurate, a posterior capsulorhexis, the intraocular lens in the bag, and an anterior vitrectomy. The postoperative inflammation control and postoperative amblyopia management is very, very important. And of course, a lifelong of follow-up is what is required for every eye. For these are eyes that you have to take care throughout their lives. Thank you very much for your patient hearing.
Superb clutch of videos, Partha, covering almost every conceivable situation. Hope we can discuss something. I mean, is Arup's presentation ready?
No, sir, not yet, sir. If Dr. Basak sir can present his, then sirs will get it. Dr. Arup's ready, sir.
Yeah, go ahead, Sama. It's about
Okay. Thank you, Dr. Ramamurthy, and thank you, Dr. Elan, for giving this nice opportunity to share some experiences. Can you see my slides?
Yes, very well.
So I'll be talking on management of DM detachment in cataract surgery. I do not have any financial interest. So you see that DM detachment happens in almost all on our hand, and the total or central DMD is not so uncommon, and this talk is on this larger detachment. Minor detachment happens in many cases we see in the side sports and main ports, but those are not very important. The causes are blunt blades, phacoprobe, hydration of ports, and maybe spontaneous. It may happen after femtocataract via the main wound and also via the side ports. Some inherent corneal pathology like weak DM stromal attachment in some of the cases like posterior polymorphous corneal dystrophy and Fuchs endothelial corneal dystrophy. I'll start my first case. Otherwise, you see the surgery was beautiful. And look carefully at the left side port of the surgeon. The surgeon is trying to hydrate the side ports, and while hydrating the left side port, you see there is a detachment of the central area. So what to do next? It is just like a type 1 big bubble in Dalk surgery. The surgeon next step, this is not by me, but in our hospital by one of the senior surgeon, he just put little air. And this air actually is sufficient in this type of cases. And next day, the patient was doing fine. And this next case is done by me quite a few years back. And you see that again, the left side port is the culprit. You see the fluid wave. And while replay, you can see with slower motion, you can see again the fluid wave, beautiful fluid wave. So you can see the fluttering of the DM inside the anterior chamber. So what to do next? I thought it is from the left-hand side, so I put air from my right-hand side port, and you see that the air is in the interface. So because the air is not circular, I realized that, and I try to see what is happening. That time there was not much knowledge about the DM detachment. About maybe 8-9 years back this happened. But again, I tried the main port because I thought I have not disturbed the main port. Again, I was in the interface between the DM and posterior stroma. Then I made a stab wound with a 30 gauge needle at 6 o'clock position and put AR from 6 o'clock position. Now I am in the right position behind the descent membrane. So, but it is like a fish mouthing kind of fish bubble kind of appearance. And I put more air from the right side port because I wanted to verify what was the position. And now I am sure that this whole layer is in the anterior chamber, and you can see the DM folds are there. And I enlarged the bubble to limbus with sufficient tamponade, and I kept the patient for a few minutes, and then the DM is get attached, and you have to leave the AR for a few minutes. Then you need to do AR-BSS exchange in this case. So this is day 1, this is day 7, and this is day 21. And surprisingly, you see the small DM folds in the center of the cornea. This is another case. This is done elsewhere. This was after 7 days. The patient was referred for DSEC surgery. And you see the otherwise very good surgery. And if you see clearly that from the slit lamp examination, there is a DM detachment in the almost lower 2/3, but upper 1/3 part is very, cornea is clear. So I did anterior segment AOCT, and you see that there is a DM attached in the upper part in the vertical section. But in the horizontal section, you see that all the DM is detached. So I took the patient in the OR next day, and from the clear side, I entered it with a different stab wound. And again, same principle of injecting air. Slowly to maintain a good tamponade. And you can keep this air for half an hour to 45 minutes and check the tension of the globe. And after 60 minutes, you see that cornea becomes clear. And we took this patient to the OR again. We just send the patient in the recovery room, and you see the cornea become absolutely clear. And then again, same kind of triradiate folds when the DM detachment is much higher. So you exchange blood with AR-BSS exchange, keep little air, about 6 to 7 millimeter, and that is all. You put extra suture if needed. This patient, after 4 hours, you see the cornea exceptionally clear. I checked with ASOCT, it is also showed that DM is attached there. And this is after 6 days, same patient, you see crystal clear cornea with very good appearance, and the patient is having 6-part vision. This was the presentation. This is a surprising case. The doctor rang me and said that I have not touched the eye. I just attempted to enter the anterior chamber, but I do not know what happened. Probably something has happened. He sent it for DM detachment. And this is, you see that I have seen these cases now, almost 3-4 cases. You see that I checked his conversation. He was not entered into the anterior chamber. So what I did, I punctured the DM with 30 gauge needle, entered into the anterior chamber. Slowly I inject the air. And you see that I have to reinforce the ear with multiple puncture, and this is 360-degree limbus to limbus detachment. This is a patient of posterior polymorphous corneal dystrophy. I check the tension, there is a fold, so I need to give more tamponade. This is only by ear. So you do give a long tract into the corneal stroma, and then the tension seems adequate. And this is a part-operative OCT I have checked because I was not sure how the thing was. And then I changed with little ARBSS exchange, and this patient was doing absolutely fine post-operatively. This is after 1 day. You see that cornea is cleared and the half of the AR was done and the patient was doing fine. This is a case, you see the lower part detached is corneal edematous, and we have done this is after 3 months, the patient, and you see there is a detachment in the lower third of the cornea, but the patient presented at 3 months. And if you see, look carefully, there is also, I cleared in the same way, and you see there is also another culprit was there, that is a nuclear fragment. So I took that is after 5 days, and I took this out after 2 weeks because I give time to DM attached firmly. This is my last case. This is case, it is an in-house case, and other doctors has done this. They have tried 3 times, and last time they have tried with some suturing. And if you see that there is a taut DM in this, and this is almost 3 weeks. And this is the challenging case, and because it was in-house case and I had to counsel the patient, I had to do right thing. So I thought I will be giving C3F8 injection, and I removed the sutures. And this was only central detachment, so I have the liberty to use any of the quadrant. And then I took the lower part because I had to do the inferior PI in this case because I need to give C3F8 gas. And there is every possibility of pupillary block with C3F8. So you need to, and the gas will be staying there for almost 10 to 14 days. So I did inferior PI, and then I inject air through side ports. This is inject a C3F8 gas actually. So you see that the tamponade in this case must be in higher so that you can feel the pressure in the eyeball is more than like 40. And in this position, you keep the patient for about an hour and take the patient again. I did venting incision in this case, and you see that from the venting incision, again with the 30 gauge needle, the fluid is coming out. Probably some viscofilled material was trapped in that area, and while I was going in, it was coming out. So this is very important in some of the cases. People also do try to do little bit desmetopexy from inside. This is from externally. So you give the tamponade should be very nice in this particular case. So this is the immediately during the recovery room, I took the ASOCT picture, and then I did little burping of the gas without the air fluid exchange. This is after 7 days, DM is attached. And you see this, there is little gap is also there on day 7, but this is after 4 weeks, and you see the cornea is almost clear, and the patient regained 6/12 part vision. So this is the specular microscopy of this particular patient, fairly well, and I know this patient will do good for a longer period of time. So sequence of events in this case is like this. And this is the 2.5 years. So you always try a AR or C3F8 desmotopexy like the previous case after 2.5 years. And this patient also fixed with AR desmotopexy. This is AR desmotopexy. And this is the power of AR bubble. And this patient was doing fine. And this is after 3 weeks. And this is the specular one. And this is the case reported in literature. The 10 years of DM detachment even can be fixed with C3F8 or any AR injection. And this was published in 2012. So take home message is don't get panic, keep your cool. Try to locate attached area of DM with care. In case of any doubt, close the wound immediately. If you have an access, go for ASOCT. Also in late cases, go for anterior segment ASOCT always. Select the area for AR injection and either via new port or via 30 gauge needle. Keep full chamber AR for 40 minutes, half an hour, depending upon the amount of detachment. A barbed little AR, or you can do a AR BSS exchange. Injection C3F8 is required in rare cases, but always you do with inferior PI. DM detachment can be fixed even after months. AR is a very powerful instrument. Right referral at right time to save time and for reputation of your own and our colleagues. Thank you very much.
Excellent, Samar. I mean, truly, again, a very nice collection of cases. While Arup's video is getting connected, just a quick question. When do you use AR and when C3F8? Because I saw that even for an inferior detachment, in some of these cases you used AR. Can we connect Arup's?
I usually prefer AR. Most of the cases, except it is a very old detachment, or if it is like limbus to limbus detachment. Otherwise, AR, maybe my 10% cases are C3F8. But inferior detachment, again, very difficult to do an inferior PI. So you have to be very careful about that. So in that case, the approach will be you just go with a long stromal puncture with a 30 gauge needle and then inject slowly little bit of air to see how the DM is attaching to that. And you can see the folds of DM. Once you are sure that you are actually lifting DM, then
please stop sharing and no, please stop sharing and so that they can share.
Okay, sure. Stop share.
Sir, there is enough time, sir. Nothing to worry about. At least 20 minutes is there, sir. Aram can do it, sir.
Okay. I'm glad that there is a time zone difference between Bangalore and us. Great.
Sorry, sir.
No, good to know the 20 minutes difference. Well, I think, Partha, a couple of questions for you. What is the usual IOL power calculation formula that you use in your cases?
In my cases, sir?
No, Partha, is he there?
Partha.
Okay.
Dr. Hermans, you were talking about the formula that you use. I generally go towards the Barrett 2K formula, and that seems to work reasonably well for me. And as regards using toric intraocular lenses, the only comment I have to make is that we are getting good results with these patients, but the basic dictum is whether it is toric IOL or toric phakic intraocular lenses. If the patient has an astigmatism which is getting corrected only with contact lenses, please don't put a toric intraocular lens, because the toric intraocular lens is only going to correct the astigmatism that is correctable with glasses. So subsequent to the toric intraocular lens, even contact lenses will not be available. So if the patient has had good vision with